Subsequently, from the idea of the study and just explaining why those patients may get a higher pathologic complete response, we aim to study the immunoscore. And you know, the immunoscore is a validated tool now, specifically in stage 2 colon cancer, to decide whether the patient is high risk or low risk. So that we decide on whether to give the patient adjuvant chemotherapy or not. And the idea of immunoscore is to calculate the density of CD3 and CD8 in the core, tumor core, and at the infiltrative margins. So we'll have at least 4 figures from these calculations, and this translates to percentile, and the mean of the 4 percentile, we call it as immunoscore. So this is simply the methodology. We have either low, intermediate, or high immunoscore. Usually the low and intermediate, they go together with the high immunoscore, they have better outcome. So patient with infiltrative margin or tumor core with CD8, they may be protected more for recurrence rate, or maybe this is due to the immune reaction of our body toward the tumor. So the idea in whether to use immunotherapy in this category of patients will improve the outcome. And subsequently in our presentation, we show that those patients with a pathologic complete response, they tend to have a high immune score. And the cutoff of 62 is the difference between the high and intermediate low. So these 15 patients with pathologic complete response, they show immune score, mean immune score of 68, a significant p-value. So we prove that those with pathologic complete response, they have a high immune score. So the second step is go to wider, maybe proof of the concept. It's to apply it to a wider number of patients, maybe retrospective data. We can calculate it and get the result very rapid. And subsequently, if we prove the concept of the high immune score as a selective biomarker for chemoimmunotherapy in locally advanced rectal cancer. This is the main idea. And using this idea is to move to those patients with a higher PCR to have what they call organ preservation instead of surgery. Because most of the ideas now in rectal cancer is going toward the organ preservation. So this is a sort of a biomarker selection for those that may have a better outcome and response rate, specifically PCR with chemoimmunotherapy. So those patients can be selected for organ preservation.